Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Doug, and we are talking about COVID-19 in the austere environment. Hey, Doug, how's it going?
Hey, good, Dennis. Nice to be with you.
Awesome. So you also work outside the military at a civilian hospital. Have you been seeing any patients?
Personally, I have not. I work in our cardiac intensive care unit, where we provide all the ECMO capability for the hospital, and we're very thankful we haven't any COVID patients who are sick enough to need venous ECMO. But I'm certainly part of the planning, and we have cases in our hospital, so I'm learning about how we're treating them from my colleagues in those ICUs.
Awesome. Well, thankfully you don't have to deal with it in the heavy doses. Some other people have to, but because of that, maybe you have a little bit of time to kind of think about what you plan on doing going forward. Can you give us like an overview of what the problem actually is, at least when it comes to oxygenation, ventilation of these patients?
Right. So, in reading some of the commentary from people on the front lines, and some of the world's expert intensivists when it comes to ARDS and ventilator strategies for ARDS are actually in Italy. So sadly, they're having to put their expertise, to the test on their neighbors and their country people. There's a few things that stand out about COVID-19 relative to ARDS. And so I'm going to review a couple of concepts first, if that's okay.
Yeah, absolutely.
So, first I want to talk about the concept of compliance, pulmonary compliance. So compliance is a term that refers to the elasticity or the distensibility of the lung as a system. And compliance is both internal, which refers to how elastic and distensible generally the small airways, the alveoli and the bronchioles are. And then it's also external, which refers to the resistance of structures around the lungs, such as the chest and the diaphragm, etc. And, an example of poor external compliance would be burn patients that we've talked about on prior podcasts, where an eschar over the chest can make it really difficult to expand the lung against the eschar, and we think about doing eschorotomies for that. ARDS is a disease of decreased small airway compliance, and that compliance is decreased because the lining of the alveoli are attacked by an inflammatory response that causes the lining of the alveoli to kind of slough and collect in kind of a protein-like collection in the alveoli themselves that is very stiff. And so in ARDS, one of the physiologic characteristics is you have very low internal pulmonary compliance. And so you need a fair amount of pressure. Number one is you get a fairly high pressure on your vent as you're trying to oxygenate these people, and you need a fairly high levels of mean airway pressure to open up these stiff alveoli so that they can exchange oxygen for carbon dioxide. We call that recruitment. And we've talked about this in other podcasts that you recruit stuck together stiff alveoli with things like high PEEP, positive end expiratory pressure. What's interesting about COVID is it seems like the compliance in these severe states of hypoxia is relatively normal. It's not low like we see in ARDS. And that has led people to think about, well, is this a disease? Is your oxygenation problem coming from the alveoli, where you would expect compliance to be low, or what we think might be happening now, is it coming from impaired circulation, where the capillaries that deliver blood to the alveoli to be oxygenated and to have carbon dioxide removed, is there a problem with them? And there's some evidence that that is the case, that there is a hypercoagulable state or a coagulopathy that's causing clotting in the microcirculation of the lung. And so your oxygen is low because blood is just not flowing through the capillaries, but your compliance is relatively good because the airways themselves, the alveoli and the bronchioles, are relatively healthy.
Now, with very limited supplies as far as assessments goes, what can not having labs necessarily, what can I do for assessments to suss out this patient who is going to go down this trajectory where he's going to need a lot of help?
Right. Well, I think, in the austere environment, in the age of COVID, if you have a patient who has a cough, who has a fever, and who has any impaired oxygenation at all, as evidenced by low saturations on a pulse oximeter, they sort of have COVID until proven otherwise. And, you're probably not going to have the test, at your location, and you're not going to get one back easily. And we're struggling in our hospitals in the United States to get the number of tests we need, and certainly to turn around a result quickly. So I would just go based on their clinical picture, relatively simple tools.
Mm-hmm. So you're talking SpO2, maybe ultrasound, something like that?
Ultrasound is interesting. There is actually some good resources about ultrasound findings in COVID. You can, Google search for these and get some tutorials and get some images on YouTube. The website for the ultrasound manufacturer Butterfly, and I'm sure other ultrasound manufacturers as well, potentially Philips and GE, are all have some tutorials and some discussions that I think would be good reference. If you have ultrasound capabilities at your location, this would be part of my pre-mission planning, or if you're on a mission, your on-the-job training is to access these and do some practicing of lung ultrasound, which is something typically we don't talk a lot about in full-on field care, because up until now, trauma has been our big focus, and we're looking for bleeding. But it's a very, lung ultrasound is a pretty simple skill to teach yourself, and there's some pretty classic findings.
Yeah, I'm trying to get with Bill to do a ultrasound podcast just on respiratory ultrasound.
Right.
And we'll throw some videos and things like that in it. So I guess, whether assessments you're kind of just diagnosing just on, like, we're just assuming that he has COVID-19 because he's got a fever, maybe some difficulty breathing. So we're going to assume until proven otherwise.
Absolutely. Yep.
But what is our kind of approach as far as oxygenating this patient? Because just sitting still, he's probably somewhat hypoxic. So what can we do to help this?
Right. So there's sort of several degrees of affliction with COVID-19. There's your completely asymptomatic patient, which you're not going to see because they're asymptomatic. We're not seeing them either. Then there's your patient with mild symptoms. They're having shortness of breath and, decreased exercise tolerance, with exercise, whether that's walking, whether it's walking up a hill, whether it's actually working out. And I would call that sort of mild symptoms. And then you're having kind of moderate symptoms where they are short of breath and they have low oxygen saturations at rest, that's probably your most concerning bunch of patients, because they're the ones, who, if they get worse, are going to become your sickest patients. And those are your patients who are, in obvious respiratory distress. They're working hard to breathe. They're not able to get at it. Their oxygen saturations may be below 80% even at rest. And you put, supplemental oxygen onto them with, a Soros, an oxygen concentrator, or a D-cell, and you're not able to oxygenate them. And then you're thinking about, putting in an airway and supporting them with a ventilator or a bag if you don't have a ventilator. Mm-hmm. So those are kind of the three, those are kind of the three levels of symptoms that you would see.
Okay. So I've heard a lot lately that, if they're hypoxic, at rest, we probably need to start thinking about taking their airway right away, because they're very likely to decompensate. What do you think about doing that right now, knowing that in a prolonged environment that's very resource intensive?
Yeah, there are two schools of thought on that. You could take their airway right away, and then you're dedicating scarce resources right away. You could give them a trial of observation with some less invasive procedures. So, I think we'll probably get down to the take their airway and vent strategies here in a little bit. But let me talk about, maybe some things you could do that are an in-between strategy where you can monitor them closely. And if that's not working, then, proceed toward intubation or cric or trach and ventilator support. So one thing that does seem to be working for these patients, there are two things that could be working. One is, optimize their non-invasive oxygen supplementation if you have the resources. So, put them on a non-rebreather or some sort of mask oxygenation. Uh-huh. If you're doing that, I would then do something that's not being talked about a lot, but we are seeing is effective in the hospitals, which is put them in a prone position. So a chest down position, basically sleeping on their stomach, head turned to the side. Okay. And, we've seen that this works in ARDS. We've seen it works in ARDS very well, in, recent study in the New England Journal. Because it redistributes more of your airway on the lower lobes of the lung into a position where it can be more easily recruited, i.e. sitting at the top of the patient, less affected by structures over it, keeping it from being recruited, like structures like the heart and the chest wall, for instance. It also seems like it might be working in COVID, and maybe working in COVID more, because it also redistributes those capillaries that are supplying those alveoli in the lower lobe to less resistance to blood flow for the same reasons. So it redistributes blood flow as effectively as it redistributes recruitability of the alveoli. And we and many other hospitals are actually proning non-intubated patients and seeing some decent results as a result. And so what you could do with these patients who are hypoxic at rest is, give them some more supplemental oxygen if you can, and even if you can't, prone them unintubated and continue to observe them. And now if they're going downhill in prone positioning, without being intubated, without ventilator support, then absolutely, rule number one in critical care medicine, trends are king. Uh-huh. If those trends are getting worse and you'll know it, then absolutely they're going to need to be intubated. And, the more stable they can be when they're intubated, the less risky the intubation procedure is. And by intubation, I'm going to use intubation and placing a surgical airway interchangeably.
Okay. Just one quick thing. When you're proning, how long do you leave them prone before you make a decision one direction or the other?
Well,
I mean, it depends,
I
of
thought you were
course.
going to ask me a different question. I thought you were going to say, how long do you leave them prone in a cycle of 24 hours? But I'll answer your question first. I would say as long as they are stable, let's say respirations that are not too labored, oxygenation that's good enough, let's say mid to high 80s%, and stable at that level, I would leave them.
Okay.
If their respiratory rate goes up, rises from the mid 20s to the high 20s to the low 30s to 40, if their, work of breathing, is labored and doesn't ease at all, and they're working hard to breathe and they're using accessory muscles, that would be when I would, turn them supine and place a definitive airway and put them on a ventilator or bag with a PEEP valve.
Okay. Now, when you, and I'll let you answer your question here in just a second, but when you initially prone somebody, there can be changes as far as their vital signs, respiratory rate, hemodynamics initially, but then they'll return back to normal.
Yeah, generally we see the change in vitals with the critically ill patients, the ones who are intubated, not so much the ones who are not as critically ill. I wouldn't expect to see a huge, drop in their blood pressure or increase in heart rate when I initially prone them. I just say, hey, lie on your stomach, turn your head to your side, put an arm above your head if that's more comfortable, and just lay like that. I wouldn't expect to see their vital signs tank. And if they did, they equilibrate, relatively quickly within minutes or so.
Okay. Now, so we've put the patient in the prone. So far they're stable. They're remaining stable. How long in the 24-hour period do we leave them in the prone position?
Basically, as long as you can. The data is all with intubated patients in ARDS, and that data says, a minimum of 16 hours prone, a minimum of 4 hours supine, lying on your back. For reasons of, comfort and sedation and anxiety, I don't know if you can get away with that in an unintubated, unsedated patient, but I would certainly shoot for as long as possible. And, I might give them some gentle anxiolysis, a couple milligrams of midazolam, or, a little bit of Precedex if you have it, or just some reassurance to help them be comfortable. But longer the better.
Right. Now let's say this patient starts to decline over a period of time. Our proning is not working as well as we hoped, or we don't have enough oxygen as we'd like to give him.
Yeah.
Now we decide, hey, we're probably going to have to take their airway. This decision alone is not really fixing the problem. Like, you putting a tube in his neck is not going to fix the problem.
Right. Well, then you're putting a tube in his neck because giving oxygenation supplementally through the nasopharynx or oropharynx isn't working to get that, distributed down into the lung. You're going to have to apply it more directly to the lung with positive pressure. And then, your options are positive pressure, as we've talked about, in an austere environment for any hypoxic process, whether that's pneumonia or ARDS or bad pulmonary edema. Ideally you're going to have a ventilator, and you're going to be able to provide supplemental oxygen up to 100%, and you're going to be able to provide positive end expiratory pressure, or PEEP. Less ideally, you don't have any of that, and all you can provide is positive pressure ventilation with a bag and a PEEP valve. Or I guess somewhere maybe in the middle, you would have a ventilator and not enough oxygen.
Right.
Sort of the good, better, best.
Right. Now, what we're trying to get is more FiO2.
Right.
But as a second best, we're going to play with PEEP to get our oxygenation. Is that correct?
We're going to play with PEEP and exactly.
Okay. Where, I guess, initially, where would you want to start?
I would probably start I would probably start at a PEEP of 5, just because, that's physiologic or close to physiologic, and just see how they go. If their oxygenation is really low, like 60s, 70s, I probably wouldn't wait around at a PEEP of 5. I'd probably give them 10.
Okay.
The issue with PEEP in COVID is that there's a fine line between providing enough PEEP that you are providing enough mean airway pressure to get oxygen, to recruit alveoli, and so much PEEP that you're actually compromising the circulation to those alveoli by compressing those capillaries, which may already be diseased and coagulopathic.
Right. No, absolutely. So, I mean, that kind of leads me to my next question is at least the way I think of every ventilation issue is actually both a respiratory and a cardiovascular components to it. And what we're trying to do is get the ventilation and perfusion matched or optimized.
Correct.
Now, initially, at least what I've heard of these patients, they're breathing very rapidly because they're trying to oxygenate themselves and not able to do that they're actually dehydrating themselves just because they're breathing. So I guess, how do I balance perfusion, either through urine output, blood pressures, etc., with oxygenation with my PEEP?
Yeah, this is a really tricky problem it's a tricky problem in all hypoxic respiratory failure. It's a really tricky problem in COVID because obviously you want to make sure their intervascular volume is ideal, because that's going to provide, that's going to keep those alveolar capillaries open. What you don't want to do is drive it either beyond ideal or continue to drive it when there's no response, because one of the conditions that may be going on with this is, not only are they coagulopathic with, microthrombi, small blood clots in the small airways of the lungs, but they may also have an endotheliopathy where the lining of those capillaries is dysfunctional and prone to leakage, and then all that fluid that you're giving them is just going into the alveoli and making and adding a ventilation problem that they didn't have to the perfusion problem that we know they have. So, I would say, here's where potentially ultrasound can be your friend. And again, we just don't have a good way to measure the adequacy of microcirculatory perfusion.
Right.
Which is really what the problem is. It's not, we can measure macrocirculatory volume pretty well. We can look at the left ventricle. Is it adequately full enough? Is it low and the walls of it are, their heart is tachycardic and the ventricular walls are coming close together, hyperdynamic and underfilled? Is the inferior vena cava, an adequate diameter, sort of, above 1.5 centimeters, less than 2.5 centimeters? Is it collapsible? We can look at all of that, but those are only surrogates for how much blood flow is getting through the microcirculation. But I would say, if since that's all we have, then that's all we can use. And if their heart looks like the left ventricle is full enough and the IVC is not collapsible, and their oxygenation isn't getting better with fluid, then stop, because you're just going to make a capillary leak problem worse with more fluid.
Right.
If you have colloid, people are going to argue about the data on this, and justifiably so, because there probably isn't a great data pro or minus. But physiologically, a colloid is more likely to stay in the intervascular space than a crystalloid will, right?
Right.
Rehydrating with a colloid is probably not a bad idea, whether that be, albumin or freeze-dried plasma or plasma.
Okay. And that would probably help with some other components of this kind of cascade, the cytokine storm, I would imagine as well.
Potentially, this whole concept of endotheliopathy, which is basically a revved up, disordered lining of the blood vessels, which is where a lot of these pro-inflammatory cytokines live. At steady state, we all have these cytokines just hanging out in the walls of our blood vessels. And they are triggered by hypoxia to come off the lining of the blood vessels, circulate in the bloodstream to parts of the brain and other organs that are involved in an inflammatory response, and get revved up. And that exists in all shock states, whether that's, hemorrhagic, hypovolemic due to hemorrhage, sepsis, cardiogenic. And there's data, again, not from COVID-19, but from trauma, that plasma resuscitation and platelet resuscitation may help damp down this endothelial response. And this is very hypothetical. I wouldn't, this is, kind of a discussion for the podcast to get people thinking, not a, hey, there's evidence to do this. But,
Right.
As you and I were talking about before we started recording, I want to reach out to some of my friends who are doing primary research on this and see, number one, do they think there's an endotheliopathy in the pulmonary microcirculation? And if so, do they think that the resuscitation strategies that have shown some promise in trauma could be applied to the perfusion problems in COVID-19?
Yeah. Is there one benefit over the other, criking versus intubating? Because thus far, everybody's been pushing intubation.
No, I don't think so. I go back to the dictum that we have in austere medicine, that the best way to obtain a definitive airway is the method that you have the most confidence you can obtain safely.
Okay. Will there be any more increased risk for aerosolization with either?
There's almost certainly more increased risk of aerosolization with intubation.
Okay, just because you're so close to his face?
Right. That's where the stuff comes out.
Right.
You're right over the face, especially with direct laryngoscopy. You're so close to the face. And that's one of the reasons that most airway experts are suggesting that we do video-assisted placement of the endotracheal tube, whether that's with a glide scope or some other variant, video assisted, because you can be at more of a standoff from the patient. And the one patient that I've had who was a COVID rule out that I had to intubate, we used video assisted laryngoscopy for that reason, and we had a pretty good intubation.
Right. But it's more going with what you're comfortable with.
Correct. And I'm, far more comfortable placing a endotracheal tube than I am with doing crikes. So I would much rather take the risk of aerosolization for a procedure I know that I can do than reduce that risk of aerosolization and put the patient at risk from a procedure that I'm not very good at.
Right. No, I definitely understand that completely. When now after intubation or after crike, there's always your post airway drugs that you end up having to use.
Sure.
Do you think you'll be able to get the ventilation? That's assuming that we need to use a ventilator on this patient.
Mm-hmm.
Would you be able to do that through a crike, and still avoid having to paralyze a patient?
I think so. One of the aspects of paralysis that isn't talked about as much, we talk about paralysis for ventilator synchrony a lot.
Mm-hmm.
The other big thing that paralysis provides, which is similar to very deep sedation, by the way, is that when a patient is tachypnic and working really hard to breathe and drawing on all those accessory muscles, those are really big oxygen-consuming muscle groups.
Right.
And so if you can take their oxygen consumption out of the demand game, then you have to supply less oxygen for the rest of the body.
Right.
And so, deep sedation or paralysis, I think can be beneficial. There are a lot of people who would argue with me about this, who are favor of light sedation, minimal sedation, and I take their point. But when your patient's going south and their sats are dropping into the 50s, and they're starting to get bradycardic, you're no longer in a perfect world of minimal sedation and following commands and walking them on the ventilator. You're still very much in the stabilization mode of critical illness. In that case, you need tools that are appropriate to the stabilization mode, and deep sedation or paralysis can be those.
Okay.
And obviously you can't paralyze without deeply sedating first.
Right. Right. Well, you could, but you're a dick if you do.
No, I mean, the patient, the patient will have PTSD that is, should haunt not only them, but you.
Right.
If they're paralyzed and not sedated.
Right. Right.
So it's malpractice to do that, and that's just not an option. Don't even think about it. You have to have the drugs to deeply sedate any patient that you're going to paralyze, and you have to monitor them very closely to make sure that they're deeply sedated as well. And if you have any questions at all, keep the paralytic in the med cabinet. Right.
And I asked just because, at least in my scope of practice, we don't have any paralytics, period. So I'm wondering, am I going to be able to drive this guy deep enough using ketamine or opioids or benzos in combination to actually get to the ventilatory rates and PEEPs that I need to do in order to oxygenate this guy?
Right. And I think, in an austere environment, I would keep paralysis on the shelf to be done only under telemedicine guidance, and just aim for a deeper sedation than we if needed, than we normally advocate in our sedation and analgesia guidelines, with a ketamine drip, with pushes of midazolam, and aiming for a RASS of -3 rather than the -1 or -2 that we normally do.
Right.
If they're that hypoxic, or they're that anxious, or they're working that hard.
Right. Now, I mean, if your sedation package is not good enough, I mean, is it obvious to, when you look at the patient, like you can tell that they are not comfortable?
Yeah. Oh, you mean when they're paralyzed, or just sedated?
No, just sedated. Just sedated.
Yeah, of course. They're still tachypnic. They're fidgety. Hypoxia tends to make people restless.
Okay.
And they'll be really anxious. But you have other tools, right? You have reassurance. You have holding their hand. Obviously at some risk to yourself if they're a COVID patient, but again, we're in a minimum better best
right
scenario here. You may have to draw on some of these other techniques.
Oh, of course. Now, as far as the austere environment dealing with this COVID patient, I'm imagining whoever is taking care of this patient, that's all he's doing.
Right.
He's probably not wandering through the camp.
Absolutely. These patients, and we're talking about this subset of COVID patients who is critically ill from unstable hypoxic respiratory failure. They are absolutely a one-to-one.
Mm-hmm.
And they're a tiring one-to-one.
Right. Oh, yeah. I have no doubt it's going to be a lot. It's going to be a lot of work, especially as this patient progresses. Ventilatory rates, ventilation is going to be a big issue, and in balancing that with the hemodynamics and balancing with your sedation package and lots of telemedicine calls, I'm sure.
Absolutely. Hopefully you have the phone in the room and you're on speakerphone to somebody on the advisor line or your other telemedicine resources, and you've got a good, intensivist on the other end, on FaceTime,
right?
Because that's certainly going to be reassuring.
Oh yeah, absolutely. I don't know, what else can we add to this?
I think just to reiterate, for COVID-19, not all patients are going to be this critically ill. You're going to have a range where most patients are going to have minimal symptoms. They're going to, either need some supplemental oxygen or just observation. You're going to have more patients who are moderately ill who are going to need some supplemental oxygenation and, awake prone positioning or non-intubated prone positioning. And then you're going to have, the tip is going to be these really critical patients who are obviously the scariest and the ones, we're probably least prepared to handle and we want to plan for. That'll be your most resource intensive. The next thing I would say is, proning is a skill that I would absolutely brush up on, read up on, and practice as much as you can before you go into these environments, because it's free oxygen and it's free perfusion. Mm-hmm. It doesn't require any drugs. It doesn't require any D-cells or Soroses. But the time to practice it is not when you need it. Not when a patient is in front of you.
Right.
There are tons of resources. The New England Journal of Medicine has a great how-to video of proning an intubated patient. What I learned in our ICU is, and I think what probably a lot of others are doing, is that if you have to prone this sedated patient, put a blanket under them or a sheet under them, a blanket on top of them, or a sheet on top of them, and roll those two together to kind of encase them in almost like a burrito, and move the patient in that burrito through the 90-degree roll and then the 180-degree roll. And our medical intensive care nurses came and taught us that when we had a patient we proned recently for respiratory failure due to a different cause. It was a cardiac arrest patient, not with COVID. And boy, it sure worked slick.
Yeah, very good.
So that's number 2. Number 3, I would definitely be happy with good enough, right? You've heard me say this on podcasts before. Perfection is the enemy of the good, of good. Be happy with, a patient who's breathing steadily in the high 20s to low 30s with minimal accessory muscle use. Be happy with oxygen saturations in the mid to high 80s that are stable and not getting worse. Be happy with blood pressures that are in the, 90 systolic or mean arterial pressures in the 60 range, and stable, because everything you do to make any one of those numbers better can potentially harm your patient in COVID.
Right.
And just observe them. And then the last thing is, balance the mean airway pressure you deliver with PEEP against the risk of impairing pulmonary perfusion. And if you're thinking about driving your PEEPs into the teens to 20 range and your patient's getting worse, enlist telemedicine to see what you're missing. And then the very last thing I would say is reach out to telemedicine for some of these novel therapies that are being talked about in sort of fast-breaking literature right now, such as, anticoagulating your patient against the microthrombi risk and when to do that, and, potentially using plasma as a resuscitation fluid for the endotheliopathy.
Excellent. Well, thank you, Doug, very much for coming on and talking with us about this.
Oh, you're welcome. I'm sorry that these are, the times that we live in and that we have to have these discussions. And, if I can help our brothers and sisters out there in an austere environment be a little bit more ready, or even just a little bit more confident in their readiness. It's a real privilege.
Yeah, thank you.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.